So good afternoon, everyone. Welcome to the 54th annual meeting of the American Society of Clinical Oncology, ASCO. My name is Dr. Richard Shilsky. I'm Senior Vice President and Chief Medical Officer at ASCO. I want to thank everyone for joining us here this year for what we are sure is going to be another exciting and practice-changing ASCO meeting. Looks like we're on track for another record setter. We're expecting more than 39,000 attendees from around the world. And as you know, it's the largest clinical cancer research meeting every year. ASCO features what we believe to be important and practice-changing research, and some of those abstracts have been selected to discuss with you today and over the next several days. So over the next 5 days, we'll highlight research that spans the entire spectrum of cancer care, from prevention and diagnosis to treatment and survivorship. Many of these advances touch on the theme of this year's annual meeting. As I'm sure many of you know, each year the ASCO president selects a theme for the annual meeting. And this year, Dr. Johnson selected the theme of delivering discoveries, expanding the reach of precision medicine. And the intent is to illustrate the profound ways in which precision medicine is transforming cancer care. We're going to hold 4 press briefings at this year's meeting. So in addition to today's meeting, there'll essentially be a daily briefing on Saturday, Sunday, and Monday, each beginning at 8 a.m. Central Time each morning. Sunday's press briefing, as is customarily the case, will highlight research from ASCO's plenary session. Today's briefing features 5 presentations that explore issues related to quality and access to cancer care, including cost, racial and gender disparities, and communication regarding age-related concerns for older patients with cancer. Joining me on the podium in the back row are ASCO experts Dr. Rob Dreiser and Dr. Joshua Jones, who will provide additional context and commentary about the studies highlighted today. You'll hear from them at the relevant times following the presentations by the abstract authors. We do ask that in your coverage of the meeting, you please use our ASCO titles for purposes of attribution. And with that, I think we can get on. I'll just mention that I think our sort of run of show is that we're going to ask each of the abstract presenters to make their presentations. We'll have some expert commentary following each of those. We'll hold all questions, though, until all of the abstract presentations have been completed, and then we will have an open mic and invite your questions. So with that, please join me in welcoming Dr. Todd Yasevsky, a senior fellow at the Fred Hutchinson Cancer Research Center in Seattle and the University of Washington School of Medicine, who will make his presentation. Todd.
So thank you, Dr. Shilsky, and thanks for the organizers for inviting me today to share our research on treatment patterns, cost, and outcomes for patients with metastatic colorectal cancer in Western Washington and British Columbia. This was a collaborative project that we did at the Fred Hutchinson Cancer Research Center along with the BC Cancer Agency. So I'm sure all of us are aware that the United States and Canada have very different healthcare systems. Most patients in the United States are covered by private healthcare plans. They're generally employer-sponsored. Public coverage is generally reserved for the elderly and low-income patients. On the contrary, Canada has universal public coverage with additional private coverage for ancillary services such as prescription drugs. Several studies have shown that overall healthcare utilization and costs in the U.S. are higher than in Canada. However, outcomes are generally similar, if not worse, in the U.S. There have really, though, been very few studies that have looked at treatment patterns, cost, and outcomes associated with a specific disease such as colorectal cancer. And this is what we set out to do. The patients that we selected for this study were those with metastatic colorectal cancer diagnosed in 2010 or later in Western Washington and British Columbia. In British Columbia, we were able to use the BC Cancer Registry, and in Western Washington, we utilized a linkage between the SEER Cancer Registry and claims data from 2 of the largest insurers in the region. Of note, this does exclude Medicare patients in the United States who are generally older and more likely to have a diagnosis of cancer. We collected information and compared the data regarding demographics, systemic therapy use, cost, and survival. And all costs were represented in 2009 US dollars. This first table shows some of the basic demographics of the two groups and also some of the first-line systemic therapy use. As expected, as I said, from the databases that we were using, patients in Western Washington were slightly younger than those in British Columbia, with a median age of 60 versus 66 years. Systemic therapy use was also more common in Western Washington, with 79% of patients getting systemic treatment versus 68% in British Columbia. Of those who did receive chemotherapy, the duration of the first line was similar between the two groups. One difference, though, was in the regimen of chemotherapy used. In Western Washington, FOLFOX was the most common, and FOLFIRI with bevacizumab the most common in British Columbia. When we looked at cost, we saw that in general, cost in Western Washington was significantly higher than in British Columbia. We looked at, in order to account for differences in treatment duration, we looked at all costs in per patient per month. For the first line of chemotherapy, costs in Western Washington were generally over $12,000 compared to just over $6,000 in British Columbia. If you looked at the most common first-line regimen, FOLFOX was still more expensive than FOLFIRI and bevacizumab, even though bevacizumab is generally considered an expensive drug. Over the course of time from a patient's diagnosis until death, chemotherapy still cost more in Western Washington than British Columbia, nearly $8,000 in Western Washington and $5,000 in British Columbia. Despite these differences, overall survival was very similar. When we looked at patients who were treated with systemic therapy, median survival was 21 months in Western Washington and 22 in British Columbia. If we included all patients who received therapy and those who did not, overall survival was still similar at around 17 months. So what can we say from this? Well, I think, despite significantly higher costs, patients in Western Washington didn't do any better than those in British Columbia. So a way of saying this is that they got the same bang for more buck. And that's nice, but how do we translate this into some differences? And we think that drug prices in Canada are generally set by the government. In the United States, we believe that if Medicare is allowed to negotiate drug prices with pharmaceutical companies, drug prices can be lower, and private insurers will oftentimes follow suit with less cost for drugs. We plan on continuing this work by including Medicare patients to the Western Washington cohort, which should hopefully increase the age and make the two groups a little bit more comparable, and looking at other aspects of healthcare utilization, such as total duration of chemotherapy, hospital use, radiation, and surgery. So, thank you.
Well, thanks very much, Dr. Yasevsky. I think the key points about this have been made. It's possible to get equally good outcomes at lower cost in other healthcare systems. It's just interesting to keep in mind, I'm sure we'll come back to this during some of your questions, that the United States is probably the only country in the world where we actually have no real way of constraining the cost of healthcare, certainly as it relates to the cost of drugs. I mean, if you think about it, the U.S. FDA does not consider drug price in any of their deliberations about safety and efficacy and whether or not drugs should be allowed to enter the market. Once they're on the market, Medicare is generally required by law to pay for the cost of the drugs. The private insurers typically follow suit. And so, there really is no way to, in any way, put any brakes on the system, which is not the case in most other healthcare systems in the world, where there is typically a regulatory authority that determines whether or not the drug is sufficiently safe and effective to be made available to the relevant population. But then there's another agency, either a government agency or a government-appointed body, that does some sort of health technology or value assessment to determine whether or not the healthcare system can actually afford to introduce the drug to their population. And that, of course, is at least the hypothesized reason for why in Canada you can get what would generally be considered a very expensive treatment regimen in the U.S. at half the cost of what it takes to deliver a similar regimen in the U.S. and still get equivalent outcomes. So we'll come back to that in the question session. I'm sure you'll have a lot of thoughts you want to follow up on. So with that, we're going to turn to two abstracts that really talk a lot about health disparities, particularly in men with prostate cancer. So our next presentation will discuss the results from an analysis of overall survival for black and white men in the U.S. with metastatic prostate cancer treated with chemotherapy on clinical trials. The lead author is actually a good friend and longtime colleague of mine, Dr. Susan Hallaby, who is professor of biostatistics and bioinformatics at Duke University in Durham, North Carolina, and she will present the study. Susan?
Thank you, Dr. Shilsky. Good afternoon, and thank you for your interest. On behalf of my co-authors, I would like to thank the ASCO Cancer Communications Committee for selecting this abstract for the press program. Despite the overall declining trends, Thank you. Despite the overall declining trends in incidence and mortality rates, African American men have higher incidence and mortality rates than white men. In addition, they are diagnosed at a later stage for prostate cancer than Caucasian men. They have unequal access to health care. Based on that information, we sought to test this hypothesis that African American men who are enrolled on clinical trials with docetaxel and prednisone and who have advanced and lethal prostate cancer known as metastatic castration-resistant prostate cancer have worse survival outcome than Caucasian men. In order to test this hypothesis, we identified 10 trials that met our inclusion criteria that comprised of men who were not previously treated with chemotherapy, and all trials must be phase 3 trials with a primary outcome of overall survival. We had therefore access to 9 trials with nearly 9,000 men. Of the 8,820 men with advanced prostate cancer, 85% were Caucasian, 6% were African American, 5% were Asian, and 4% were other or unknown. I'm going to focus only on the 8,028 men who were either white or Caucasian to test our primary hypothesis. So what we found is that the National Cancer Institute, National Clinical Trials Network had enrolled a higher proportion of African American men than industry-sponsored trials. It's 12% versus 4%. It is important, though, to note that the National Cancer Institute, National Clinical Trials Network were conducted in the U.S., whereas industry-sponsored trials were conducted globally. In a first analysis, looking at the aggregate data, the survival distribution in African American and Caucasian men appeared to be the same, with a median survival duration of 21 months. When we zoom in and we perform another type of analysis that adjusts for important variables that will affect the outcome, to our surprise, what we found is that the relative risk of death was 19% lower for African American men than Caucasian men. and this was statistically significant. When we restrict our analysis to the 3 trials that were conducted by the National Clinical Trials Network in the US, the results are even more striking, with the median survival for African American men of 21 months versus 20 months in Caucasian men. And the risk of death in an adjusted analysis was 24% lower for African American men than Caucasian men. This was also statistically significant. To summarize, this is the largest analysis comparing survival outcomes in African American versus Caucasian men in men with advanced and lethal prostate cancer that are treated with docetaxel and prednisone. The enrollment rate of African American men was low. It is estimated in 2018 that the African American population in the US is about 14%. The median survival time was 21 months in both groups, and adjusting for important factors, African American men had 19% lower risk for death than Caucasian men enrolled on all trials. When we focus only on the trials that were conducted by the National Clinical Trials Network, African American men had 24% lower risk for death than Caucasian men. These results are from phase 3 clinical trials, and therefore they cannot be generalized to the US population. New methodologies for enrolling higher numbers of African American men should be actively pursued and vigorously implemented so minority groups are well represented on trials. Thank you for your attention.
Thank you very much, Susan. Very interesting data. I'm going to ask Dr. Rob Dreiser, an expert in prostate cancer and one of ASCO's designated experts for this session, to offer a few comments for some context. Rob?
Thanks, Dr. Shilsky. Despite my colleagues' emphasis that this cannot be generalized to the U.S. population, I would argue that what this tells us is pretty striking, that African American men have a potentially better survival by getting conventional therapy. Now, this was enrolled on trials, but this is a conventional therapy, the chemotherapy we're talking about. So I think access to care is emphasized here. The nihilism associated with prostate cancer in African American men is not supported by this really interesting work. What it says to us is we treat men with advanced prostate cancer who are African American, they do well.
So the bottom line is, in a sense, that African American men with advanced prostate cancer need to get to an oncologist, ideally need to get on a clinical trial, and if they do, their outcomes are every bit as good as Caucasian men, if not even a little bit better. So we're going to continue this theme with the next abstract presentation. This features findings from a prospective study comparing metastatic prostate cancer response to hormone treatment in black or white men in the U.S. The lead author, also from Duke, is Dr. Dan George, professor of medicine and surgery. Dan.
Thank you, Dr. Shulsky, and thank you, ASCO, for selecting our abstract for presentation here today. This is a different study than what Dr. Halaby just presented. This is a much smaller study, but this is a prospective study. And the reason that's important is because there is no selection here. These are patients that are now being prospectively selected, not retrospectively selected. And they're really complementary approaches to very much a similar question. And I think I just went backwards, so let me go forwards again. As Dr. Halaby had mentioned, there is a higher risk of death associated from prostate cancer with African Americans than with Caucasians. And I've shown that here schematically. There's a 1.6 times greater likelihood that African Americans are diagnosed with prostate cancer, but a 2.4 times greater chance they die from that disease. And although there very well may be multifactorial reasons for that, I think some of this is genetic. And the reason we believe some of this is genetic is because if you look at the white patients in this SEER database and compare them to Asian American patients, you see about a twofold difference in death from prostate cancer for white patients versus Asian American patients. Now, we're not saying that the Caucasian patients have less access to care or are undertreated compared to Asian American patients. We're saying that there are probably genetic differences associated with these ethnic and racial types that may be factoring in to the survival with this cancer. And I think when you look at Asian Americans versus African Americans, it's a five-fold difference in terms of death from prostate cancer. That's pretty dramatic. We wanted to look in prostate cancer treatment prospectively because when we looked retrospectively, as Dr. Halabi did, we saw a similar trend. Now, the numbers were terribly small. This is the Cougar 302 study, one of those industry-sponsored international global studies that Dr. Halabi mentioned. And in this 1,100-patient trial, there are 28 black patients. African Americans and European African descent patients totaled 28. And when we looked at them, they were randomized 1-to-1, so 15 of them actually got the abiraterone drug, a sort of newer hormonal therapy that's shown a survival benefit in this setting of castration-resistant or lethal prostate cancer. And in those 15 patients, we actually saw differences in terms of their PSA responsiveness. A biomarker of their response to the therapy was better than what we saw in the overall population. And their median time to progression, their time to disease relapse was longer, was 16 months versus 11 months in the general population. Now, these numbers were too small to statistically draw any conclusions. But we looked in our own database at Duke and our own practices in African Americans and in Caucasian patients, and we actually controlled them for prior exposure to chemotherapy so that we matched them 1-to-2 for every single African American patient. We had 2 Caucasian patients, and we saw the same trend, higher PSA responsiveness to this abiraterone drug in the African American population versus the Caucasian population, wherever we drew the cutoff, whether it was a small decline in PSA, a great decline in PSA, or no decline at all. So we did this study, this ABI-RACE prospective study, and it took us almost 3 years to accrue this study. It started out as a single institutional study. We had to make it a multi-institutional study to get it done, but we did it, and we were able to accrue 100 patients treated with the standard indication for abiraterone and prednisone, irrespective of race, and followed them for outcome, disease progression, or adverse event. This was a non-comparative study. This was not a phase 3 large 1,000-patient trial. We didn't believe we could do that. But this was to look at each racial group independently at their outcomes and then to be able to see if there were trends between them. These are the background characteristics, and I'll just point out they're very similar. It's interesting that the white patients had a higher percentage of Sipuleucel T use. And Sipuleucel T is one of the therapies that we think there may also be a difference in outcome associated with race. It's an immunotherapy. And there was a difference in chemotherapy in favor of the white patients as well. And that was, again, sort of an aggressive use of chemotherapy in the pre-hormone-resistant or castrate-resistant state. There were differences in baseline characteristics. The African American patients had higher rates of hypertension, hyperglycemia, and hypercholesterolemia, many factors that would have excluded them from those large prospective phase 3 studies. We chose a liberal criteria to allow patients on the study in order to maximize the eligibility for our populations. This was the radiographic progression-free survival, and as you can see, it's very similar between the two. Importantly, African Americans didn't show any trend to a worse outcome, as we might have expected from that higher rate of death from prostate cancer. And I think a larger study would be necessary to show any statistical difference between these populations. Interestingly, when we look at our PSA response rate, we see a very similar trend to what was seen in the 2 retrospective analyses. Across the board, at every threshold, 30, 50, and 90% PSA decline were higher in the African American group than in the white group. And we even saw a much greater rate of what we call a tumor flare, where new lesions appear while the PSA is declining, suggesting there might be a different biologic response to this therapy in African American patients versus Caucasian patients. When, again, we look at the median time to PSA progression, we again see the median time of 16 months for our black patients versus 11 months for our Caucasian patients, very similar to what was seen in the Cougar 302 study for the overall population. And toxicity was different as well. It's interesting, in yellow are the toxicities higher in the African American patients by greater than 10%, and you can see that hyperglycemia, hypokalemia, and hot flashes, all hormonal-based toxicities, either through the adrenal gland, pancreas, or other mechanisms, seem to be higher in our African American population than in our white population, suggesting perhaps a greater exposure risk to this medicine. And then finally, by race, we can actually look not simply at self-described race, but actually at the percent of African ancestry. And why this is important is because we're going to be looking at specific genes that might be responsible for these differences by African ancestry. And they do cluster. There is an admixture. African Americans are not 100% African descent, but they are largely African descent. And that predominance is going to allow us to look at African ancestry differences. And there are differences by African ancestry. These are two genes that are involved in androgen transport. Taking androgens or testosterone hormones from the blood and into the cell is a critical step for these cells to be able to respond to hormonal therapy. It's also a transporter for the drug abiraterone, which is also a steroid. And we can see big differences by race, and African Americans have much higher rates of certain subtypes of this gene, what we call single nucleotide polymorphisms, that have been shown in other studies to correlate with the effectiveness of transporting testosterone or abiraterone into the cell. So we'll be able to look at this by race to see if there are actual differences that can account for the changes we see. So 3 take-home messages for us. One, race studies done by racial groups are possible. Despite the low incidence in our national or international studies, we can do this. 2, we absolutely need to do this because there are differences in both outcomes of treatment as well as side effects that could have significant implications in how we use and when we use these drugs. And third, that there are genetic differences underlying race, and we need to understand what those are and how they correspond with these outcomes. Thank you very much.
Thank you, Dan. So let me turn it back to Dr. Dreiser for a few additional comments.
I think this was a very important study, and I think part of the reason why it's important is because it gets to the issues of when you think about personalized medicine. What Dr. George has described is basically now prospective evidence that there are biological differences that explain response to drugs. Now, we've known this, but the reality is the work hasn't been done. So this suggests 2 issues. We've talked about access to care, right? We've now demonstrated that if you treat African Americans with standard of care drugs for advanced prostate cancer, there's compelling evidence that they respond as well or maybe better than white men. And 2, beginning to understand the differences that drive differential responses. When African American men are underrepresented in clinical trials, the trial outcomes might be different, frankly, because people respond differently to drugs. I think those are the take-homes.
Great, thanks. So I'll take the moderator's prerogative. I just want to ask you one quick question. I think you said it took 3 years for you to complete the enrollment on the study, yes, which seems like a long time for a relatively small number of patients with a very common cancer getting a standard of care treatment. So what I'm curious about is, did both populations enroll at the same rate, or did you finish enrolling all the white patients in the first year and then took 2 more years to finish enrolling the black patients, or just curious?
It's a great question, and there's 2 answers to that. First is that one of our biggest problems, we underestimated our ability to accrue to this study, and we started as a Duke University and Duke Cancer Network study, and we were unsuccessful in accruing in the first year. And so we went back to the sponsor who gave us more funding to make it a multi-center study. And through the Prostate Cancer Clinical Trials Consortium, with support from the Prostate Cancer Foundation, who actually helped develop abiraterone, we were able to then finish the accrual, about 70% of the accrual in the last year. So, and the key things that helped us accrue were going to sites where we had champions for this cause, going to sites where we had access to African American patients, and where we had clinical trial infrastructure. They weren't necessarily the sites with the greatest number of African American patients, but they had to have clinical champions, and we had to have clinical infrastructure. And no, we didn't accrue at the same rate. We had to put our Caucasian accrual on hold at multiple times, because even at Duke, we have 70% Caucasian patients versus 30% African American patients. But what we're able to show is over the same time period the study accrued. So with occasional starts and stops on our Caucasian patients, we are able to accrue the last 70% of patients over the last year on schedule for both races to finish.
Great. Thanks a lot for that clarification. So let's go on to our next presentation, sort of same general theme about disparities in treatment and outcomes, but different disease and different group of patients. So our next speaker will present the results from a study analyzing the likelihood of receiving intensive treatment for head and neck cancer in women versus men. The senior study author is Dr. Jed Katzel, a medical oncologist at Kaiser Permanente in Santa Clara, California, and he'll present the study. Jed.
Thank you. My name is Jed Katzel. I'm an oncologist specializing in the clinical care of patients with head and neck cancer at Kaiser Permanente in Santa Clara, California. On behalf of myself and our research team, we would like to thank the organizing committee of ASCO and the press program for the opportunity to share our results. The title of our abstract is Are Women with Head and Neck Cancer Undertreated? Analysis using a generalized competing events model. Oh, I did the same thing. Okay. So, the treatment of head and neck cancer often requires intensive treatment that can have lasting side effects. Our goal was to review data from a large group of patients in Northern California to determine which patients are most likely to benefit from aggressive therapy while minimizing toxicity for those likely to die from competing events. Standard survival curves do not take into account non-cancer causes of death. So we decided to evaluate our cohort using something called a GCE model. Our study population included 884 patients with head and neck cancer, 223 women, and 661 men that were diagnosed with head and neck cancer between the years of 2000 and 2015. This is the key slide for our presentation. Sorry. The GCE model is a mathematical model that can be used to calculate something called an omega plus score for a patient. The omega plus score, shown here on the left, is the hazard for cancer mortality over the hazard for non-cancer mortality. It essentially describes the degree to which cancer is the patient's problem. And I'm going to provide two examples. The first example is a person with a slow-growing cancer who lives, for example, in a war zone, who may be blown up the minute they leave their home. For that patient, cancer is not the main problem, and their omega plus score would be low. The second example is a patient with an aggressive cancer who lives in the countryside with a low risk of non-cancer mortality. For the second patient, cancer mortality is the problem, and the omega plus score is high. The GCE scores can also be compared between groups, as shown here on the right, as an omega plus ratio. In our trial, we compared omega plus scores for women with omega plus scores for men. Key findings. Using the GCE model, we found that women were more likely to die from head and neck cancer than from other causes. Men were also more likely to die from head and neck cancer than from other causes. However, the omega plus score for women was 7, and the average omega plus score for men was 3.8. For women, the ratio of head and neck cancer death to non-cancer death was approximately double the ratio for men, despite controlling for other factors like age and other comorbidities. However, there were some confounders that we want to mention. There were a lower percentage of oropharyngeal head and neck cancers in women compared with men. There were a small number of non-cancer deaths in women in our cohort. There were only 19 non-cancer deaths in women. And if you recall, the Omega Plus score is the ratio of cancer mortality over non-cancer mortality. So if the women in our cohort were actually more healthy than men, it would derive the same mathematical ratio. Another key finding was that fewer women than men received combined chemotherapy and radiation therapy on logistic regression analysis, while the rates of surgery were similar between women and men. This may be a reflection of differences in the primary tumor location in our cohort, with relatively more oral cavity cancers in women compared with men, and relatively fewer oral pharynx cancers in women compared with men. Groups were significantly different in terms of age and primary tumor location. Summary and take-home points. On GCE analysis, for women, the ratio of head and neck cancer death to non-cancer death was approximately double the ratio for men, despite controlling for other factors like age and comorbidities. This was a retrospective analysis that included 884 patients with head and neck cancer. Further investigation is needed to determine if there's an actual difference in treatment and outcomes for women compared with men. To this end, we have planned a chart-by-chart review, as well as prospective analysis that will be performed in the currently enrolling NRG HN004 clinical trial. I would like to acknowledge my research team, Annie Park, Amy Alabaster, Hanji Shen, and Lauren Mell, as well as the ASCO organizing committee for this opportunity. Thank you.
Thanks very much, Dr. Katzel. So I'd now like to call on ASCO expert Dr. Joshua Jones to make some additional comments and put this abstract in some context. Josh.
Thanks so much. This is a really striking study. This was a model, as you saw, a mathematical model to help us define which patients should get intensive treatment for head and neck cancer. And that treatment can be very intensive. Radiation, chemotherapy can have significant side effects. But the outcome of the study was very surprising to us. The idea that there are disparities in both the treatment that women receive compared to men, but also disparities in the rate of death from head and neck cancer for women compared to men. We don't know why those differences exist, but it's really important that we continue this research, that we continue to figure out what those differences are, why they're happening, so that we can make sure that as we're talking to patients with head and neck cancer, that we're providing the right treatment for the right patient at the right time, and that everybody has the appropriate access to outstanding clinical care for head and neck cancer.
Great. Thanks so much. Let me ask one question. I love being up here, so I get to ask all the questions first. It seems that one emerging important prognostic factor that you didn't mention is HPV status. And did you look at that and control for that in your analysis?
It's a really good question. I don't know if this is on. Yeah. So it's a great question. We did not directly check HPV status on the patients in our cohort.
You think that is related, is a possible explanation for some of the differences in outcome by anatomic site that you identified?
It's really a great question. So our GC analysis was designed to take into account tumor location. However, I understand your question. I think it's really quite a good one. Our populations were different in terms of tumor location. So for example, oropharynx cancer, the percentage of oropharynx cancer in women was only 38%, while in men the rate of oropharynx cancer was 55%. And that was statistically significant difference. And we know that the HPV-related head and neck cancers are more likely to occur in the oropharynx, and we know that those HPV-related head and neck cancers have a better prognosis and a better response to therapy.
So something to keep looking at as you continue your work. So thanks very much. So our next presentation is going to address another kind of health disparity, and this has to do with the management of older patients with cancer. Of course, most cancer patients are older. They tend to be greatly underrepresented in clinical trials, so we don't actually know nearly as much about how best to treat them as we would like to, even though they're the ones we're treating most often. So the final presentation will feature findings from a randomized trial exploring whether geriatric assessment improves communication with older patients with cancer. I'm particularly pleased and proud to introduce the lead author for this study, Supriya Mohil, who was one of our hematology oncology fellows at the University of Chicago many years ago when I was on the faculty there. And it's very gratifying to see all that she's accomplished in her career. She's the Wertheim Professor of Medicine at the University of Rochester and an expert in geriatric oncology, and she'll present the results of the study. Supriya.
Thank you. It's very exciting for me to be here, and I want to thank you all for coming, and I want to thank ASCO, the organizing committee, for allowing us to present our research to you today. On behalf of my co-investigators, it's a pleasure for me to present the results of our cluster randomized controlled trial that was conducted at the University of Rochester NCI Community Oncology Research Program that evaluated if geriatric assessment can improve communication with older adults with cancer. We all know the population is aging, and in fact, the fastest growing population of patients with cancer are those aged 70 and over. Most older patients with advanced cancer want treatment, but only if it does not negatively affect other health issues. Physicians often don't know patients' and caregivers' age-related concerns, such as concerns about memory or concerns about falling. Many patients and caregivers do not ask about age-related concerns because of their unclear understanding of the relevance of those issues to an oncology clinical encounter. Geriatric assessment is an approach that's used in geriatrics clinics. It's an approach to the evaluation of an older patient, and it evaluates geriatric domains that are known to predict morbidity and mortality in older patients. In fact, a recent ASCO guideline summarizes the robust level of evidence that shows that a geriatric assessment can help identify older patients at highest risk of adverse outcomes. The geriatric domains that are listed here are high priority for older patients with cancer and their caregivers. For example, someone with functional impairment can have problems with independence. Someone who has memory problems that gets chemotherapy can have more issues with confusion at home. Each geriatric assessment domain is measured using validated tools with validated cutoff scores and can guide interventions known to improve outcomes in community-dwelling older adults, for example, physical therapy for impaired functional status. While geriatric assessment has been shown to be feasible, only 20% of community oncologists use geriatric assessment in clinical practice. We conducted a cluster randomized controlled trial in our University of Rochester NCORE network where we randomized oncology practices. 31 practices enrolled patients. Patients were eligible if they were age 70 and over with advanced incurable solid tumors or lymphoma and had at least one impaired geriatric assessment domain. We were able to enroll 542 evaluable patients. The practices were randomized to two arms. In the first arm, oncologists received a geriatric assessment summary plus a list of recommended interventions. In the control arm, oncologists were notified if there was clinically significant depression or cognitive impairment, but they were not provided a summary or a list of recommendations. The geriatric assessment was completed by all patients. Usually by self-report, patients were able to take the surveys home, and on average it took them less than 30 minutes. Staff in the clinic administered cognitive and physical performance tests that took on average less than 10 minutes. In the intervention arm, the clinic staff inputted scores into a web-based portal on mycarg.org, which was password protected, and that information was provided to the oncologist before a clinic visit. In both arms, the clinic visit was audio recorded after the geriatric assessment. We found that the patients enrolled in this study had a high prevalence of impairments on geriatric assessment domains, ranging from over 90% for physical performance to 25% for psychological status, mainly depression. Of note, more than 30% of patients enrolled on this study screened positive for cognitive impairment. The majority of patients had more than 2 geriatric assessment domains impaired, with a median number of 4. These are patients that are not enrolled on our standard clinical trials due to comorbidity, disability, and frailty. The primary outcomes of our study was evaluation of direct communication about discussions related to age-related concerns in the audio-recorded clinic visit. That visit was transcribed, and people, coders, were blinded to arm, read those transcripts word for word. We used stringent criteria for coding and for reliability. In addition, we conducted telephone surveys, on average about 7 days after the clinic visit, to assess patient satisfaction. Here are the primary results. In the direct communication aim, there is a higher number of discussions about age-related concerns in the geriatric assessment intervention arm compared to control. In the geriatric assessment arm, the number of discussions was 7.74, and in the control arm, it was 4.24, and this was highly significant. In addition, the conversations had higher quality and led to more discussed interventions. In terms of patient satisfaction, we use validated tools, Healthcare Climate Questionnaire, which was modified for age-related concerns, as well as Healthcare Climate Questionnaire for overall satisfaction. We found that in the geriatric assessment arm, patient satisfaction scores were 1.12 points higher on average than in the control arm, with a p-value of 0.027. And these differences in satisfaction persisted up to 3 months after the intervention, and involved not just satisfaction about age-related concerns, but overall satisfaction with care. So in conclusion, a web-based geriatric assessment summary with recommendations for interventions improved patient-centered outcomes, including direct communication about age-related health concerns and patient satisfaction with communication. The strengths of this study are that it's a nationwide study using our University of Rochester NCORE network, and it was cluster randomized at the practice level. In addition, we used a unique mixed methods approach that integrated both qualitative and quantitative data to assess communication. This study is the first to evaluate geriatric assessment in a cluster randomized controlled trial, which was large, 542 patients, for older patients with advanced cancer, and lends further support to the new ASCO guideline, which recommends geriatric assessment for all patients undergoing chemotherapy. As a geriatric oncologist, I'm very passionate about these results, and the geriatric oncology community will partner with ASCO and other groups like the Cancer and Aging Research Group to continue to support and help practices implement geriatric assessment for their patients. I want to thank the Patient-Centered Outcomes Research Institute and the NCI for funding this study. In addition, I want to give a special shout out to Beverly Kanan and Mary Whitehead over there, who are part of our patient advocacy board that partnered with us through this research process from the beginning to the end of the study, and at my request came here to support me. Thank you.
Thanks very much, Supriya. So, Dr. Jones, any comments you'd like to add?
Indeed. This is a very important study that I think is likely to have a direct impact on the care of our older patients with cancer. This study shows in a randomized fashion that we can, with a simple intervention, improve communication about what's really important to older patients with cancer. We have interventions, things like physical therapy, things like counseling, supports that can be provided to patients and families as they're thinking through treatment decisions, helping us to provide the most appropriate care for these individuals. So with a simple, validated assessment, we can make sure that we are understanding what is most important to our patients and providing the right kind of care that they want.
Great. So I have one question for you too, Supriya. And I might have missed this in your description of the, of the control group. But I'm curious, I'm curious as to your thoughts about the importance of the geriatric assessment itself, as opposed to that just being a mechanism for better communication with the healthcare team. So in other words, if the patients in the control group, or in the control centers, if you will, had simply been given instruction to write down things you're concerned about and, bring them into your next doctor's visit, do you think that that would have stimulated the same level of discussion?
So that's an interesting question. It may have helped to some extent. I think what happens in our geriatric oncology clinics, we have one at University of Rochester where we see older patients with cancer all the time. And I think there's unclear understanding on both the side of patients and caregivers as well as oncologists about what could be relevant. And so if you ask them to write down what is important to them as concerns, it may not highlight the memory issues or the falls or the worry about the mom who's taking care of their spouse who has dementia and how now she has cancer and she's getting treatment. How is she going to take care of her husband? Those things, in oncology, we have limited time in the clinics. We're very focused on the cancer and the treatment. And those things are important, but they don't rise to the top. When patients come to see an oncologist, they're thinking about their cancer. So this sort of provides permission for people to talk about this, and I think will lead to better decision-making for treatment, and also better care overall.
That's great. Great.